Hello, everybody. Good afternoon. I'm James, and today I'll be presenting to you guys chronic obstructive pulmonary disease featuring the Mr. Nazal case study. So today I'll be discussing an in-depth A to E assessment on the symptoms experienced by Mr. Nazal, and I'll also be going over some highly essential interventions and considerations we as nurses must take when managing patients such as Mr. Nazal. So firstly, we'll be talking about his airways. Mr. Nazal's airways are patent and he's maintaining them independently, as stated in his handover, which indicates there are no immediate obstructions or compromises to his airways. But given he does have a past medical history of COPD, which is detailed in his medical history, continuous monitoring is especially important in ensuring his airways stay clear to prevent further deterioration. This is super important as one of the symptoms associated with COPD and infection includes a buildup of mucus, which is a natural immunological response. However, in patients with COPD, this may cause blockages that can restrict airways. Hence, close monitoring of his airways is still essential, despite them being patent. So next we'll be discussing his breathing. So Mr. Nazal's respiratory rate is 30 breaths per minute, far from the normal range of 12 to 20. This is a sign of severe tachypnea, a hallmark symptom of respiratory distress and COPD exacerbation. Oxygen saturations are falling as low as 78%, well below the normal range of 95 to 100%. This requires immediate oxygen supplementation. The hypoxia that's likely due to COVID-19 induced inflammation in the lungs furthers the urgency for non-invasive ventilation, including nasal prongs, to increase oxygen levels and reduce breathing workload. A blood gas analysis should also be done to see the levels of carbon dioxide retained in order to administer a more effective dose of oxygen to prevent hypercapnia. So next we'll be talking about Mr. Nazal's circulation. So Mr. Nazal's heart rate exceeds the normal ranges of 60 to 100 beats per minute at 128 beats per minute and has a blood pressure of 168/85, meaning he is tachycardic and hypertensive. This is related to his hypoxia. Due to the lack of oxygen, Mr. Nazal is experiencing a compensatory response due to his sympathetic system being stimulated. His slow capillary refill at 3 seconds and cold peripherals indicate lessened peripheral perfusion, a sign of circulatory compromise. Monitoring for signs of worsening hypoperfusion and close evaluation of his cardiovascular status, such as the use of an ECG machine, may be needed to assess any potential cardiac complications as a result of his hypoxia. So next we'll be discussing disability. So Mr. Nazal's GCS is 14/15, which indicates he's experiencing mild confusion. This is highly likely also related to his hypoxia. Compromised levels of oxygen will mean less oxygen is reaching important parts of his body, such as the brain. Cerebral oxygenation will be compromised. This area of the brain is responsible for his thinking skills. This calls for close monitoring as prolonged periods of hypoxia can lead to severe health complications, contributing to further deterioration. Improving his oxygenation status, is the most essential intervention to prevent further neurological decline. Lastly, we'll be discussing Mr. Nazal's exposure. So Mr. Nazal has a fever. This is most likely his body's natural immunological response against the COVID-19 infection. This infection can cause further inflammation in his respiratory region, further worsening his respiratory distress. The use of antipyretic drugs may benefit Mr. Nazal by lowering levels of inflammation, easing his symptoms. This allows him to feel a little bit more comfortable, lessening his stress levels and improving his breathing. So now that we have discussed his A to E assessment, these are 4 high priority nursing interventions we can take to help manage the symptoms he's experiencing. So firstly, we will discuss supplemental oxygen. Administering supplemental oxygen to keep SpO2 levels between 88 to 92% is vital in preventing hypoxia without increasing the risk of hypercapnia, which often happens in patients suffering from COPD, which is the result of impaired gas exchange. Frequent and regular SpO2 monitoring will help tailor the oxygen therapy provided and can help avoid further respiratory compromise. High flow oxygen may be needed in cases of acute exacerbations. However, this requires close monitoring to ensure the balance of oxygenation is kept at a good balance to help reduce CO2 retention. Supplemental oxygen in Mr. Nazal's situation will drastically alleviate many of his out-of-range vital signs, as well as his mild confusion. With proper SpO2 levels and proper gas exchange via SpO2 supplementation, we can further prevent implications from hypoxia. His GCS can be brought back to 15, improving neurological deterioration by ensuring adequate oxygen is reaching his brain and other vital organs. Supplemental oxygen can also help lower the amount of work he puts into breathing, reducing his stress and discomfort. So next we'll be talking about intensive spirometers. So because Mr. Nazal has a reduced lung capacity, using an intensive spirometer can help in promoting with his lung expansion. This can assist with Mr. Nazal in clearing his mucus and maintaining lung strength. Especially because Mr. Nazal has not been able to breathe properly since the onset of his symptoms, as well as the supplemental oxygen, using a spirometer can ensure he maintains the capacity to breathe independently and robustly. This is especially important in patients with COPD. Spirometer exercises can benefit with alveolar recruitment. It can loosen mucosal secretions, therefore increasing gas exchange. These exercises also help in reducing the work of breathing as it strengthens respiratory muscles. Next, we'll be talking about administration of bronchodilators. The use of bronchodilators, including short-acting beta agonists or anticholinergics, are essential in alleviating bronchospasms, common in COPD exacerbations. Bronchodilators can improve airflow, enhance SpO2 uptake, and reduce dyspnea by relaxing the smooth muscles within the airways. Such medications can benefit Mr. Nazal by stabilizing his acute respiratory distress, improving his ventilation status. And finally, the last intervention we'll be discussing is the high phallus position. Positioning Mr. Nazal in a high phallus position, which is roughly about 45 to 90 degrees, enhances his lung expansion due to a reduction of pressure placed on his diaphragm, improving the mechanical functions of his breathing. The phallus position helps alleviate dyspnea, meaning better ventilation perfusion matching, enhancing oxygenation. This position also facilitates the utilization of accessory muscles, essential for patients in respiratory distress like Mr. Nazal. So now we'll be discussing some nursing considerations we must take before administering the following therapies and medications mentioned in this slide. You can read them if you want. And next slide. So firstly, we have oxygen therapy. Its assessment, monitor SpO2 levels and aim for a SpO2 level of 88 to 92% to avoid hyperoxia in COPD patients. Assess for signs of respiratory fatigue or distress. Administration. Administer oxygen via nasal prongs, face mask, or non-invasive ventilation as needed. Side effects. Monitor for CO2 retention, leading to hypercapnia. Over-oxygenation can reduce respiratory drive in COPD patients. Salbutamol. Ensure to monitor respiratory rate, chest sounds, and check heart rate pre- and post-administration to see whether it's effective. Administration. Administer via a nebulizer or metered-dose inhaler. Salbutamol acts as a short-acting beta agonist, relieving bronchospasms. Side effects. Keep an eye out for tachycardia, tremors, and palpitations due to beta adrenergic stimulation. Monitor for hyperkalemia in high doses. Ipratropium assessment. Ensure to monitor any chest sounds and respiratory effort before and after its use to see how effective it is in relieving bronchospasms. Administration. It is delivered via a nebulizer or inhaler. Ipratropium is an anticholinergic, meaning it reduces the production of mucus, alleviating airway constriction. Side effects, just keep an eye out for dry mouth, urinary retention, and dizziness due to its anticholinergic effects. Prednisolone assessment. Ensure to monitor for signs of symptoms such as infection to see how effective it is in reducing infection, BGLs, and fluid retention. Make sure you assess how well this drug reduces inflammation in the patients after use. Administration. This drug is taken orally. Prednisolone reacts as an anti-inflammatory, soothing airways during episodes of exacerbation. Side effects. Long-term use could potentially lead to hypoglycemia, immunosuppression, and fluid retention. Azithromycin. Assessment. Watch out for signs of infection and any bad reactions to the treatment, just to see if the antibiotic effects are effective in reducing the infection. This antibiotic is known to be hard on the liver, so assessing the patient's liver function, prior and after administration is essential. Administration. It can be taken orally or intravenously for its antibacterial effects. It targets underlying infections that may worsen COPD. Side effects. Keep an eye out for gastrointestinal upset and liver toxicity. Next and finally, nirmatrelvir and ritonavir assessment. Ensure renal function and liver function is assessed prior to its administration, and ensure it is taken with drugs that will not interact with it, especially in patients who are polypharmacy. Administration, this drug can be taken orally. And side effects, potential side effects include gastrointestinal issues, liver toxicity, and interactions with other drugs. These are my references. Please feel free to review them. And thank you for listening. I hope you guys all learnt something and have a good afternoon.